Hello, and welcome to the ASCO Daily News Podcast. I am your guest host, Dr. Linda Duska. I'm a professor of obstetrics and gynecology at the University of Virginia School of Medicine. On today's episode, we will explore the management of advanced ovarian cancer, specifically with respect to a question that's really stirred some controversy over time, going all the way back more than 20 years. Should we be doing radical upfront surgery in advanced ovarian cancer, or should we be doing neoadjuvant chemotherapy? So there was a lot of hype about the TRUST study, also called ENGOT, OV33, AGO-OVAR OP7, a phase 3 randomized study that compares upfront surgery with neoadjuvant chemotherapy followed by interval surgery. So I wanted to talk about that study today. And joining me for the discussion is Dr. Kathleen Moore, a professor also of obstetrics and gynecology at the University of Oklahoma and the deputy director of the Stephenson Cancer Center, also at the University of Oklahoma Health Sciences. Dr. Moore, it is so great to be speaking with you today. Thanks for doing this.
Yeah, it's fun to be here. This is going to be fun.
FYI, for our listeners, both of our full disclosures are available in the transcript of this episode. So let's just jump right in. We already alluded to the fact that the TRUST study addresses a question we've been grappling with in our field. Here's the thing. We have 4 prior randomized trials on this exact same topic. So share with me why we needed another one and what maybe was different about this one.
That is, I think, the key question. So we have to level set kind of our history. Let's start with, why is this even a question? Like, why are we even talking about this today? When we are taking care of a patient with newly diagnosed ovarian cancer, the aim of surgery in advanced ovarian cancer ideally is to prolong a patient's likelihood of disease-free survival. Or if you want to use the term remission, you can use the term remission. And I think we can all agree that our objective is to improve overall survival in a way that also doesn't compromise her quality of life through surgical complications, which can have a big effect. The standard for many decades, certainly my entire career, which is now over 20 years, has been to pursue what we call primary cytoreductive surgery, meaning you get a diagnosis and we go right to the operating room with a goal of achieving what we call no gross residual. That's very different. In the olden days, you say optimal and you get down to some predefined small amount of tumor. Now, the goal is you remove everything you can see. The alternative strategy to that is neoadjuvant chemotherapy followed by interval cytoreductive surgery. And that has been this quote unquote safer route because you chemically cytoreduce the cancer. And so the resulting surgery, I will tell you, isn't necessarily easy at all. It can still be very radical surgeries, but they tend to be less radical, less need for bowel resection, splenectomy, radical procedures, and in a short-term look would be considered safer from a post-operative consideration.
Well, and also maybe more likely to be successful, right? Because there's less disease, maybe, theoretically.
More likely to be successful in getting to no gross residual.
Right. Yeah, exactly.
I agree with that. So if the end game, regardless of timing, is you get to no gross residual and you help a patient, and there's no difference in overall survival, well, then it's a no-brainer. We wouldn't be having this conversation. But there remains a question around, while it may be more likely to get into no gross residual, it may be, I think we can all agree, a less radical, safer surgery. Do you lose survival in the long term by this approach? This has become an increasing concern because of the increase in rates of use of neoadjuvant, not only in this country, but abroad. And so you mentioned the 4 prior studies. We won't be able to go through them completely.
Let's talk about the 2 modern ones, the 2 from 2020, because neither one of them showed a difference in overall survival, which I think we can agree is, at the end of the day, yes, PFS would be great, but OS is what we're looking for.
OS is definitely what we're looking for. I do think a marked improvement in PFS, like a real prolongation in disease-free survival, for me would be also enough. A modest improvement doesn't really cut it, but if you were really, really prolonging PFS, you should see that
manifest in OS.
Yeah. Okay, so let's talk about the two modern ones. The older ones are EORTC and Chorus. The two more modern ones are Scorpion and JCOG-0602. So Scorpion was interesting. Scorpion was a very small study, so one could say it's underpowered, 170 patients. And they looked at only patients that were incredibly high risk. So they had to have a Fagoti score, I believe, of over 9. But they weren't looking at just low volume disease. Like those patients were not enrolled in Scorpion. It was patients where you really were questioning, should I go to the OR or should I do neoadjuvant? Like, what's the better thing? It's easy when it's low volume. You're like, we're going. These were the patients who are like, what should I do? High volume. Patients were young, about 55. The criticism of the older studies, there are many criticisms, but one of them is that the criticism that's lobbied is that they didn't really try. What other surgery you got, they didn't really try, with median operative times of 180 minutes for primary cytoreduction, 120 for neoadjuvant. Like you and I both know, if you're in a big primary debulking, you're there all day. It's 6 hours.
Right. And there was no quality control for those studies either.
No quality control. Scorpion, they went 451-minute median for surgery. Like they really went for it versus 4 hours. And then 253 for the interval 4 hours. They really went for it on both arms. Complete gross resection was achieved and 50% of the primary side reduced. So even though they went for it with these very long surgeries, they only got to the goal half the time. It was almost 80% in the interval group. So they were more successful. And there was absolutely no difference in PFS or OS. They were right about 15 months PFS, right about 40 months OS. JCOG-0602, of course, done in Japan, a big study, 300 patients, a little bit older population, surprisingly more stage 4 disease in the study than were in Scorpion. Scorpion did not have a lot of stage 4, despite being very bulky tumors. So third of patients were stage 4. They also had relatively shorter operative times, I would say 240 minutes for primary, 302 for interval. So still kind of short. Complete gross resection was not achieved very often. 30% of primary cytoreduction. That is not acceptable.
Well, so let's talk about TRUST. What was different about TRUST? Why was this an important study for us to see?
So the criticism of all of these, and I'm not trying to throw shade at anyone, but the criticism of all of these is if you're putting surgery to the test, you're putting the surgeon to the test, and you're assuming that all surgeons are trained equally and are willing to do what it takes to get someone to no gross residual.
And are in a center that can support the post-op care for those patients.
Which can be ICU care, prolonged time. Absolutely. So when you just open these broadly, you're assuming everyone has the surgical skills and is comfortable doing that and has backup. Everybody has an ICU. Everyone has a blood bank. And you're willing to do that. And that assumption could be wrong. And so what TRUST said is, okay, we're only going to open this as centers that have shown they can achieve a certain level of primary cytoreduction to no gross residual disease. And so there was quality criteria. It was based on, it was mostly European studies. So ESGO criteria were used to only allow certified centers to participate. They had to have a surgical volume of over 36 cytoreductive surgeries per year. So you couldn't be a low volume surgeon. Your complete resection rates that were reported had to be greater than 50% in the upfront setting. I told you on the JCOG it was 30%.
Right. So these were the best of the best. This was the best possible surgical situation you could put these patients in, right?
Absolutely. You support all the things so you could mitigate postoperative complications as well.
So we're asking the question now again in the ideal situation, right?
Right.
Which we can talk about may or may not be generalizable to real life, but that's a separate issue because we certainly don't have those conditions everywhere where people get cared for with ovarian cancer. But how would you interpret the results of this study? Did it show us anything different?
I'm going to say how we should interpret it and then what I am thinking about. It is a negative study. It was designed to show improvement in overall survival in these ideal settings in patients with FIGO stage 3B and C. They excluded A, these low volume tumors that should absolutely be getting surgery. So FIGO stage 3B and C and 4A and B that were fit enough to undergo radical surgery, randomized to primary site reduction or neoadjuvant with interval, and were all given the correct chemo.
And they were allowed Bev and PARP also. They could have Bev and PARP.
They were allowed Bev and PARP. Not many of them got PARP, but it was distributed equally. So that wouldn't be a confounder. And so that was important. Overall survival is the endpoint. It was a big study. It was almost 600 patients. So appropriately powered. So let's look at what they reported. When they looked at the patients who were enrolled, this is a large study, almost 600 patients, 345 in the primary side reductive arm and 343 in the neoadjuvant arm. Complete resection in these patients was 70% in the primary side reductive arm and 85% in the neoadjuvant arm. So in both arms was very high. So your selection of site and surgeon worked. You got people to their optimal outcome. So that's very different than any other study that has been reported today. But what we saw when we looked at overall survival was no statistical difference. The median was, and I know we don't like to talk about medians, the median in the primary side reductive arm was 54 months versus 48 months in the neoadjuvant arm with a hazard ratio of 0.89. And of course, the confidence interval crossed 1, and so this is not statistically significant. And that was the primary endpoint.
I know you're getting to this. They did look at PFS, and that was statistically significant. But to your point about what are we looking for a reasonable PFS difference, it was about 2 months difference. When I think about this study, and I know you're coming to this, what I thought was most interesting about this trial, besides the fact that the OS, the primary endpoint, was negative, was the subgroup analyses that they did. And of course, these are hypothesis generating only. But if you look at, for example, specifically only the stage 3 group, that group did seem to potentially, again, hypothesis generating, but they did seem to benefit from upfront surgery. And then one other thing that I want to touch on before we run out of time is, do we think it matters if the patient is BRCA germline positive? Do we think it matters if there is something in particular about that patient from a biomarker standpoint that's different? I'm hopeful that more data will be coming out of this study that will help inform this. Of course, unpowered, hypothesis generating only, but it's just really interesting. What do you think of their subset analysis?
Yeah, I think the subsets are what we're going to be talking about, but we have to emphasize that this was a negative trial as designed.
Absolutely. Yes.
So we can't be apologists and be like, but this or that. It was a negative trial as designed. Now I'm a human and a clinician, and I want what's best for my patients. So I'm going to go down the path of subset analyses. So if you look at the stage 3 tumors that got complete cytoreduction, which was 70% of the cases, your PFS was almost 28 months versus 21.8 months.
Yes, it becomes more significant.
Yeah, that hazard ratio is 0.69. Again, it's a subset. So even though the p-value here is statistically significant, it actually shouldn't have a p-value because it is an exploratory analysis. So we have to be very careful. But the hazard ratio is 0.69. So the hypothesis is, in this setting, if you're stage 3 and you go for it and you get someone to no gross residual versus an interval side reduction, you could potentially have a 31% reduction in the rate of progression for that patient who got primary side reduction. And you see a similar trend in the stage 3 patients if you look at overall survival, although the post-progression survival is so long, it's a little bit narrow of a margin. But I do think there's some nuggets here that one of our colleagues, who's really one of the experts in surgical studies, Dr. Mario Lateo, posted this on X. And I think it really resonated after this because we were all saying, but what about the subsets? He's like, it's a negative study. But at the end of the day, you're going to sit with your patient. The patient should be seen by a GYN oncologist or surgical oncologist with specialty in side reduction and a medical oncologist, if that person doesn't give chemo. And the decision should be made about what to do for that individual patient in that setting.
Agreed. And along those lines, if you look carefully at their data, the patients who had an upfront cytoreduction had almost twice the risk of having a stoma than the patients who had an interval cytoreduction. And they also had a higher risk of needing to have a bowel resection. The numbers were small, but still, when you look at the surgical complications, as you've already said, they're higher in the upfront group than they are in the interval group. That needs to be taken into account as well when counseling a patient, right? When you have a patient in front of you who says to you, Dr. Moore, you can take out whatever you want, but whatever you do, don't make me a bag. As long as the patient understands what that means and what they're asking us to do, I think that we need to think about that.
I think it's a great point. And I have definitely seen in our practice patients just say, I absolutely would not want an ostomy. It's a non-starter for me. And we do make different decisions. And you have to just say, that's the decision we've made. And you kind of move on and you can't look back and say, well, I wish I would have, could have, should have done something else. That's what the patient wants. Ultimately, that patient, her family, autonomous beings, they need to be fully counseled. And you need to counsel that patient as to the site that you're in, per volume of disease, and what you think you can achieve. In my opinion, a patient with stage 3 cancer who you have the site and the capabilities to get to no gross residual should go to the OR first. That's what I believe. I don't anymore think that for stage 4. I think that this is pretty convincing to me that that is probably a harmful thing. However, I want you to react to this. I think I'm going to be a little unpopular in saying this, but for me, one of the biggest take homes from TRUST was that whether or not we can talk about the subsets and the stage 3 looked better, and I think it did, but both groups did really well, like really well. And these were patients with large volume disease. This was not cherry picked small volume stage 3s that you could have done a optimal just by doing a hysterectomy. These were patients that needed radical surgery, and both did well. And so what speaks to me is that anytime you're going to operate on someone with ovary, either whether it be frontline or whether it be a primary or interval, you need a high volume surgeon. That's what I think this means to me. Like, I would want high volume surgeon at a center that can do these surgeries, getting that patient, my family member, me, to no gross residual. That is important. And you and I are both in training centers. I think we ought to take a really strong look at, are we preparing people to do the surgeries that are necessary to get someone to no gross residual 70 and 85% of the time?
We're going to run out of time, but I want to address that and ask you a provocative question. So I completely agree with what you said, that surgery is important, but I also think one of the reasons these patients in this study did so well is because all of the incredible new therapies that we have for patients. Because OS is not just about surgery. It is about surgery, but it's also about all of the amazing new therapies we have that you and others have helped us to get through clinical research. And so how much of that do you think, like, for example, if you look at the PFS and OS rates from CORUS and ERTC, I get it that they're not the same. It's different patients, different populations can't do cross-trial comparisons. But the OS, as you said, in this study was 54 months and 48 months, which is, compared to 2010, we're doing much, much better. It's not just the surgery, it's also all the amazing treatment options we have for these patients, including PARP, including MERV, including lots of other new therapies. How do you fit that into thinking about all of this?
I do think we are seeing, and we know this just from epidemiologic data, that the prevalence of ovarian cancer in many of the countries where the study was done is increasing, despite a decrease in incidence. And why is that? Because people are living longer.
People living longer, yeah.
Which is phenomenal. That's what we want. And we do have, I think, better supportive care now, PARP inhibitors in the frontline, which not many of these patients had. Now, some of them, this was mainly in Europe, will have gotten them in the first maintenance setting. And I do think that impacts outcome. We don't have that data yet, kind of see what I would be really interested to see. We don't do this well because in ovarian cancer, post-progression survival can be so long. We don't do well of tracking what people get when they come off a clinical trial to see how that could impact, how many of them got another surgery, how many of them got a PARP. I think this group probably missed the ADC wave for the most part, because this mirvetuximab is just very recently available in Europe.
Unless they were on trial.
But I think we'll have to see. 600 patients, I would bet a lot of them missed the ADC wave. So I don't know that we can say we know what drove these phenomenal. These are some of the best curves we've seen outside of BRCA. And then coming back to your point about the BRCA population here, that's a really critical question that I don't know that we're ever going to answer. There have been hypotheses around a tumor that's driven by BRCA, if you surgically cytoreduced it and then chemically cytoreduce it with chemo, and so you're starting PARP with nothing visible and likely still homogeneous clones, is that the group we cured. And then if you give chemo first before surgery, it allows more rapid development of heterogeneity and more clonal evolution, that those are patients who are less likely to be cured, even if they do get cytoreduced to nothing at interval with use of PARP inhibitor in the frontline. That is a question that many have brought up as something we would like to understand better. Like, if you're a BRCA, should you always just go for it or not? I don't know that we're ever going to really get to that. We are trying to look at some of the other studies and just see if you got neoadjuvant and you had BRCA, was anyone cured? I think that's a question on Solo One I would like to know the answer to, and I don't yet. That may help us get to that. But that's sort of something we do think about. You should have a fair number of them in trust. It wasn't a stratification factor, as I remember.
No, it wasn't. They stratified by center, age, and ECOG status.
So you would hope with randomization that you would have an equal number in each arm, and they may be able to pull that out and do a very exploratory look. But I'd be interested to see, just completely hypothesis generating, what this looks like for the patients with BRCA. And I hope that they will present that. I know they're busy at work. They have translational work. They have a lot pending with trusts. It's an incredibly rich resource that I think is going to teach us a lot. And I'm excited to see what they do next.
So outside of trust, we're out of time. I just want to give you a moment if there were any other messages that you want to share with our listeners before we wrap up.
It's an exciting time to be in GYN oncology. For so long, it was just chemo, and then the PARP inhibitors nudged us along quite a bit. We did move more patients, I believe, to the cure fraction. When we ultimately see OS, I think we'll be able to say that definitively. And that's exciting. But, that's the minority of our patients. And while HRD positive benefits tremendously from PARP, I'm not as sure we've moved as many to the cure fraction. Time will tell. But 50% of our patients have these tumors that are less HRD. They have a worse prognosis. I think we can say that, and recur more quickly. And so the advent of these antibody-drug conjugates, and we could name 20 of them in development in GYN right now, targeting tumor-associated antigens, because we're not really driven by mutations. Other than BRCA, we don't have a lot of things to come after. We're not lung cancer. We're not breast cancer. But we do have a lot of proteins on the surface of our cancers, and we're finally able to leverage that with a very active regimens. And we're in the early phases, I would say, of really understanding how best to use those, how best to position them, and which one to select for whom in a setting where there's going to be obvious overlap of the targets. So we're going to be really working this problem. It's a good problem. A lot of drugs that work pretty well. How do you individualize for a patient, the patient in front of you with 3 different markers? How do you optimize it? Where do you put them to really prolong survival? And then we finally have self-surface. We saw at ASCO CDK2 come into play here for the first time. We've got a cell cycle inhibitor. We've been working on WEE1 and ATR for a long time. CDK2s may hit. Response rates were respectable in a resistant population that was cyclin E overexpressing. We've been working on that biomarker for a long time with a toxicity profile that was surprisingly clean, which I like to see for our patients. So that's a different platform. I think we've got bispecifics on the rise. So there's a pipeline of things behind the ADCs, which is important because we need more than one thing, that makes me feel like, in the future, I'm probably not going to be using Doxil ever for platinum-resistant disease. So I'm going to be excited to retire some of those things. We'll say, remember when we used to use Doxil for platinum-resistant disease?
I'll be retired by then, but thanks for that thought.
I'll remind you.
You are right. It is such an incredibly exciting time to be taking care of ovarian cancer patients with all the opportunities. And I want to thank you for sharing your valuable insights with us on this podcast today and for your great work to advance care for patients with GYN cancers.
Likewise. Thanks for having me.
And thank you to our listeners for your time today. You will find links to the TRUST study and other studies discussed today in the transcript of this episode. Finally, if you value the insights that you hear on the ASCO Daily News Podcast, please take a moment to rate, review, and subscribe wherever you get your podcasts.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.